Hi, it is a pleasure to welcome you all to our virtual Byteflies event, the Byteflies Epilepsy Day. It's virtual. I don't think I have to explain you in these COVID times why we do that. It's to keep it safe. We have done it here as well with this plexi wall between Julie and myself to keep everything here safe as well. Nevertheless, although it's virtual, we look very much forward to join this event together with all of you at home. We're very excited to talk about technology in epilepsy. I'll be honest, my role in this evening will be very short. I will do a short introduction about Byteflies, and then I will give the word to Julie, who will be your host of the evening. So I will just say a couple of words about Byteflies. Before I go there, maybe one practical thing. It is remote, just to streamline it a little bit. We love to take questions. We love to be as interactive as possible, but please use the chat to do that. Then Julie or moderator of the panel discussions later can pick these questions up and use them as well, but that we can keep it streamlined as well. I hope everything is clear. I will say a couple of words about Byteflies, because who is Byteflies? We are a company that got started a little bit over 5 years ago. A company of 26 superstars that love working together. Impactful warriors that are positive, that are team players. With team players, we mean love to work together, but also love to work together with partners, with different stakeholders in this field, because that's important. And impactful, to have impact, not only for their own career, but also have impact in this field and on patients. Some people say there's around 50% of the people worldwide suffer from a chronic condition. I think not the most important part to discuss here, whether it's exactly 50% or less, but I think we can all agree that there's lots of people with different conditions. Tonight will be about epilepsy, but there's other diseases like COPD, asthma, cardiac diseases, MS, etc. And as we will see tonight about epilepsy, but what's also true for these other diseases is living with them is not trivial, is not ideal. So it has a lot of impact on their life. And we want to work on technology that can improve the life of these people. Because we believe that technology will revolutionize healthcare, or will have a big impact on healthcare. You know, today healthcare is very centralized hospital care. And this will evolve more and more into decentralized home care. Because if you see today, if you're sick, you know, you either go to the doctor or you go to a hospital, and at that point, there's lots of information. You're hooked up to machines, they do tests, etc. And from that specific moment, where they do a spot check, they have a lot of information. But when you go home, there's very little information. Either very subjective self-reporting or no information at all. And that's not ideal, and that will change. By technology, by remote monitoring, we will go more and more from spot checks to continuous measurements. That information that will be collected out of the hospital will go from more subjective self-reporting to more objective follow-up. And as a result, healthcare will become more and more proactive as well, where of course the hospitals will still play a very important role in the patient journey. Now, what do we see our role in this vision? We believe, or we want to give every patient access to this specialized care at home, that not only when you're in the hospital and you're hooked up to these systems that there's lots of information about you, but also when you're in your home environment. So we want to enable out-of-hospital monitoring for every patient that is accurate, that gives a lot of insights to the people themselves, but also to doctors, to specialists, to different stakeholders in this story. Now, you might think that this is not extremely original, or we didn't invent this ourselves, and lots of people are working on this, but this is also a difficult field. There's lots of evolutions, and it's clear that with COVID, a couple of things become accelerated, but nevertheless, it's a field where it's not necessarily easy to get technology, to get evolution into clinical practice. And the way how we tackle that is by where we define basically 3 circles, and our early adopter, that's the inner circle, is the researcher. We work together with researchers to gain insight of a disease, to build up credibility, and to understand how a disease works and how technology can really work for people. Then the middle circle is we work together with pharma companies, with different partners to use remote monitoring clinical trials. Because to get these tools into clinical trials, they need to be robust, they need to be scalable, they need to be give value, and they can give value to expedite trials as well. But while doing that, you build up also a scalable product that eventually can get into clinical practice, where it can give most value to the people, but which is also from a market or a field point of view, the most difficult, because you have different stakeholders. You have the patients, you have doctors, you have hospitals, you have payers, you have the companies. So it's a difficult field, but in the end of the day, this is where this technology can have the most impact. And we as a company, this is also where we want to go to. We will explain this tonight a little bit more into detail in epilepsy, because that's a field where we're very much focused on, where we have done a lot of research already, build up credibility, learned a lot on how we can have an impact there. We matured our product to have impact in clinical trials, but where we also believe now that we are at the forefront of bringing this into clinical practice. And therefore, it's very interesting to discuss tonight how to get there. There's a couple of other diseases. Of course, the first one this year, something like COVID happened, which, like I mentioned before, has expedited quite a bit of things. Also for us, we have expedited there a remote monitoring solution, which we brought to clinical practice for hospitals to keep patients outside of the hospital. A remote monitoring solution to track patients, COVID patients outside of the hospital. It's not the scope of tonight, but this is some of the things we are doing. Other diseases where we're more in the research phase, working together with big research institutes, pharma companies as well, is COPD, heart failure, post-surgical evaluation, sleep and fatigue, which has a huge impact on different diseases, multiple sclerosis, and there's a couple of others. This is something where we see a lot of things happening, where remote monitoring can also bring a lot of value. Again, not the scope of today, but just to give you an idea about what we do. Now, I hope this gave some high-level information about what we do. It's, like I mentioned, tonight will be about epilepsy. Some of the things that I mentioned will become also more clear by the presentation that Julie will give, but also very importantly, we will go further in discussions with different people around the table, which I look very much forward. Anyway, thank you very much. Welcome to everybody. I want to introduce Julie. She is one of our superstars from our Connecting the Dots team that is working on epilepsy. A lot of people are behind the screen at home, but Julie will be your host tonight and will guide you through. Thank you very much.
We'll do it safe, the transition. Thank you, Hans, for the nice introduction. And indeed, I speak for the full team working in epilepsy and beyond, that we're very excited today to openly discuss technological opportunities in epilepsy. We will set the stage with two short presentations. I will give a state of the art of our wearable solution, which is called the Sensor Dot. In epilepsy, I will be followed by our expert, Professor Dr. Wim van Pasen, who will really shed some light on some interesting clinical results that we obtained over the years. And then to better understand what these type of wearable seizure detection devices how they could improve patient care, we really need to listen to two important stakeholders. First, we will host a roundtable with people with epilepsy and their caregivers, followed by another interactive panel discussion that will focus on the perspective of 4 international neurologists. And then at the end, Hans De Clercq, our CTO and co-founder of Byteflies, will close off the event. He will consolidate the key information we learned from these 2 sessions as well, and give you a bit of glimpse into the future. So more than anything else, epilepsy is a chronic brain disorder that's really characterized by unpredictability. So we hear that a lot. It's the not knowing when a seizure is going to happen. And that, of course, inflicts a huge burden on more than actually 65 million people living with epilepsy over the world. Just imagine that you're a single mom having to take care of your baby while having that constant fear of having a seizure, or losing your driving license, which is part of our independence. And these are just a few examples of the impact of epilepsy on someone's life. We will hear much more stories about how it affects personal and professional life from the people with epilepsy itself in the first roundtable. Now, for these people, as well as for their neurologists, the road towards the right treatment and also an acceptable quality of life can be very long and cumbersome. And sadly, actually more than 30% have no working treatment at all. And despite huge investments, research, new devices, new treatments on the market, this number did not significantly change in the past 20 years. And that shows us actually, or it highlights really the problem for epilepsy today, which is we really lack information about the person's true seizure burden. And how come? Why is seizure counting so difficult? And it also helps us explain why for doctors it's also difficult to prescribe the right treatment, or for pharma to evaluate maybe new drugs in the pipeline. So why is seizure counting so difficult? For that, we need to look at the problems with current methods and their shortcomings. Of course, when you are diagnosed with epilepsy, you often have to go to the hospital for a very valuable video EEG admission. This is where they measure your brain activity while they observe with a video to correlate potential seizures with clinical symptoms. This is very accurate, very important for diagnosis, but it has one limitation. It's, again, as Han already said, it's a spot check. It's limited in time. And what then happens, so given the unpredictability of seizures, if no seizure happened in these few days in the hospital, you also have no data. Then you are sent home, and it's really up to you as a patient or as your caregiver to write down, often with pen and paper, when seizures happened. And it's widely known that these type of patient diaries are very inaccurate. More than half of the seizures go missed, especially during the night, for instance. So there's really a gap that we need to bridge here. And the solution is actually quite straightforward. And I think Hans already touched upon it in general in healthcare, so also in other diseases, this is applicable. We really need to step away from only spot checks towards more continuous monitoring. So if you look at epilepsy today, we are mostly blind towards how many seizures are happening in a certain person. So what needs to happen tomorrow is we need to include more innovation, more tools for home monitoring, for instance, through wearables. And so to speak, we actually want to unblind ourselves, and we want to replace all these gray spots today of the unknown by so-called blue squares of real-world data, because only then we will provide enough information, evidence for evidence-based decisions by neurologists, for pharma to better evaluate their drugs, and that's ultimately needed to get real seizure counts. So, of course, there have been some technological advancements already in the field of epilepsy, invasive and non-invasive. For non-invasive, there have been consumer wearables that entered already the market. And although they have, of course, they're very comfortable, but we notice that the clinical utility is not always clear. The neurologist, for instance, is also not involved in the decision to wear it. There's no raw data available. And also, often they don't measure EEG, so the brain activity, which then makes the application very narrowed for a specific niche of a group of patients and not applicable to a broader range. So since as Byteflies, we of course are very passionate about wearable health, we want to take also the advantage, and in epilepsy, we wanted to bring a more desirable solution, a comprehensive solution in the shape of an objective seizure logger. And for that, we focused on three important factors. From the beginning, we always put clinical accuracy as a high priority, but we combined that with taking into account the patient perspective, usability, so their feedback on how the device should look like. And as you can see here in the lady wearing the device, we opt for electrodes behind the ear because it's more discreet than a full scalp EEG, for instance. And then the data is processed by the sensor dot, the wearable, which can be worn in the neck. Then secondly, we also chose for a medical device rather than a consumer device that would be prescribed by the neurologist who has the medical know-how, who knows for which patients it would be applicable. And then together they can find answers to when are seizures triggered, when do they happen, how frequently do they happen, and so on. And then a third powerful aspect of our solution is that we include multiple physiological and behavioral signals that can be recorded at the same time. So our sensor dot can capture not only EEG, so brain activity, it can also record ECG, heart rate, we can detect motion, and even also muscle activity, which for some types of epilepsy can be very important. And this can actually be a game changer, because if you look at this classification table, there's many different types of seizures, and they can also manifest themselves in different parts of the brain. There's 3 big categories. It can happen very locally, which is called focal seizures, or more generalized across the brain, or unknown. Now, I won't go into too much detail. I'm sure Professor Van Pasen will explain this much better, but what is important is that they're associated with many different types of symptoms. And by actually using the advantage of our multimodal nature of the device and the flexibility to put it on different positions on the body, we can actually cover a broad group of people with epilepsy and capture a broad range of seizure types. Plus, we can also improve seizure detection itself by backing it up with multiple physiological signals. So here are our famous Byteflies circles again, which are really a guidance for us towards our North Star, which is, in this case for epilepsy, personalized care for people affected. So we indeed started from the beginning from essential research, but we feel the time is now to get into clinical practice. So I will guide you through the steps we have been taking over the years in this epilepsy vertical. So from the beginning, we realized and we accepted that epilepsy is a very complex disease. So it was key to really bring together the right partners to gain credibility, as Hans already mentioned as well. So we had the honor to work together with top epileptologists in UZ Leuven, both from the pediatric as well as the adult unit. We had input from pharma, who's lead in epilepsy drug development. We had engineers from KU Leuven, who can then work on automated seizure detection via algorithms, and product designers. And over these years, we actually measured 100 patients in the hospital. And what did we achieve with that? Well, first, we could benchmark it against the hospital system. We could show that with our prototype, our signals are from the same quality as in the hospital. Secondly, we could show that seizures are visible with these limited channels behind the ear, because we realize it's not as comprehensive as the full hospital EEG. And these 2 things were very important. But then, of course, the more interesting question was also, can we keep those high signal quality? Can we still detect seizures when we go to the home environment? So we set out the first home study where patients were sending home. They were wearing the sensor dots, as well as a kind of a reference device, an ambulatory EEG that gives us a comparison. And the outcome of this first phase was actually very successful. We could prove with the first POC that we could detect seizures, different types of seizures, both absence as well as focal, and that a neurologist is able to interpret the signals, even in a home environment. And at the same time, we also got valuable feedback from a usability point of view. So next, we wanted to scale our solution. We wanted to mature it and make it actually fit for clinical trials. For that, we, thanks to the close collaboration with UCB and discussions with them to see the potential value of an epilepsy wearable in epilepsy trials, it actually pushed us to make sure that our manufacturing facility can scale up, that we can produce at a large scale, as well as our cloud infrastructure, where all the health data goes, that it meets all the security requirements. And then a big milestone happened beginning of 2020, after a lot of hard work from the full team. We actually received medical certification both in Europe and in the US for the sensor dot being a vital signal recorder. That was, yeah, I have to mention it again. It was a big achievement, and I think we're all happy today that we achieved that. But what is also interesting after this phase, that sensor dot was actually one of the first digital tools to be integrated by pharma into drug trials, showing that they trust it, that it's secure, that it's robust, and so on. And that actually brings me to where we are now. And ambitious as we are, we don't stop here. we want to go to clinical practice, as Hans also pointed out. That's the end goal. So we got some European funding from EIT Health, and we extended the CSIT consortium. So not only with our Belgian partners, but we brought in from all over Europe key opinion leaders and top clinical teams. And we are running now at the moment a multi-center study, which is under guidance of Professor Van Paassen. We're also doing some small studies in the US, some pilots, but the key here is that we're actually amplifying the amount of clinical evidence or trying to understand the performance of our device for different seizure types and really investigating that deeper. Now, also to keep on continuously improving the device from a usability perspective, also checking how accurate are the signals in longer home studies. We're at the moment also measuring people with epilepsy in their home environment and learning what the requirements are. And some feedback is already coming that the cup electrodes, for instance, behind the ears are not always that comfortable. So we took that on, and from a product design perspective, we then embarked on other initiatives with other partners that Hans De Clercq will talk about more. But we actually are working on a smart patch with the goal of replacing these cup electrodes and make it more comfortable for people to wear longer times, longer periods. So clinical validation is ongoing. I would say stay tuned, check the publications that will come out soon. But it's really interesting to work together both with the neurologists and the people with epilepsy to get to that last circle. So building on these strong collaborations, and thanks to the input of all these key opinion leaders and people working in the different hospitals, we actually reached today already more than 250 individuals that we measured from different age groups. So we also measured some children actually. We measured data from over 500 days. And I think what is quite impressive is that we have collected more than 2,000 seizures. And it's very important here as well that they're collected in a very structured way. So this will be very important also on the longer run and for the engineers to make automated seizure detection algorithms and to go hopefully to alarming and prediction. Now, before going into a use case, I will show a short video where actually my dear colleague Astrid explains very well how the multimodal setup is, how it looks like and how it can be used.
This is our Byteflies sensor dot. It is designed to record physiological and behavioral signals, such as brain, heart, and muscle activity and motion. This allows us to create a personalized seizure profile, a little bit like a fingerprint, and monitor different types of epileptic seizures. The EEG, or brain activity signal, is measured with the help of electrodes that are attached on either sides of the head, behind the ears. The setup is very discreet and can easily be hidden. These electrodes are then connected to a sensor patch, which magnetically holds the sensor dot and transfers the data. Every 24 hours, the sensor dot needs to be put in the docking station so that it can charge and upload the data to the cloud. This allows us to access the EEG data and search for epileptic events. The dot can be swapped for another one if the patient continues to measure. Seizures can also cause the heart rate to go up, which is why it is interesting to also measure our patient's heart rhythm. Since twitching and jerking of the muscles can also indicate a seizure, we designed our sensor dot so that it can also record muscle activity. Next to the EEG configuration, the sensor dot can thus also register both ECG and EMG signals. For ECG, the patch is then worn on the chest instead of the neck. In case of EMG, a dot can be added to the muscle of interest of a specific patient.
So indeed, now I want to go a bit more in detail in a potential use case. So suppose a neurologist decide to send a person home with a sensor dot for continuous monitoring. What we then only have available as a comparator is the patient diary. Now, what kind of clinical insights can we obtain by measuring for these longer periods? Well, we could provide an automatic seizure calendar where you can see the multiple days the device was used, and on which days some events were marked as well, and compare it to the seizure diary. In this example, you can already see, and which is often what we see also in the real use cases, is that it's much more events are detected on the sensor dot than the diary, again amplifying the inaccuracy of diaries in general. Then if you would zoom in on one day, because you want to understand, okay, did these seizures happen during the day or during the night? That can be relevant for certain clinical decisions. You can have an overview in a type of event line as shown here. And then if you want to know more about one event itself, we can pull up a kind of a summary which shows you on which channels you can see a signature on the EEG, if it was correlated also with some changes in heart rate or motion, and giving you more an overview. Now, we also know that neurologists like to see as well to raw data, so they could also, by a simple click, visualize the full raw data, the EEG trace, and really compare the baseline versus where the seizure starts, when it stops, and then also correlated with, we would provide some plots that also summarize correlations with heart rate, for instance, the heart rate increasing tremendously during a seizure, but often also afterwards. So this really is the goal, to create a comprehensive overview of all the events during a longer time period that then can be used again by clinicians to make evidence-based decisions and fine-tune maybe medication or treatments. And with that, I want to end with my last slide and actually recapitulate our 3 pillars that we try to take into account when building an epilepsy wearable. It has to be clinical accurate. We use patient-centered design. We opt to go for a medical device that can be prescribed by neurologists and then be used by people with epilepsy. And we try to capture multiple physiological signals to make really a personalized seizure profile. And with that, we really hope to tackle in a way a bit that unpredictability that we mentioned in the beginning, and empower people with epilepsy and their neurologists in their journey to a better quality of life. So with that, I want to give the floor to the expert in the room, which is Professor Wim van Pasen. I'll briefly introduce him. That gives him some time to share his screen and go into more the clinical results. But I want to say we worked with Professor van Pasen already for a long time, and he is really our epilepsy mentor. We really learned a lot from him, and thanks to his team and him, actually today we are all sitting here. So I do want to express that gratitude, and looking very much forward to more detailed clinical results, which especially the neurologists in the room will be hungry for. So Wim, the floor is yours. Let us know if anything pops up, and good luck.
Good evening. Thank you for the invitation to talk on the clinical value of the sensor dots. So it's all about mobile health and digital biomarkers. It involves the application of sensors, mobile apps, social media, and location tracking technology to obtain data pertinent to wellness and disease diagnosis, prevention, and management. And that is what we are trying to do in epilepsy. When we started this work in 2016 in the CIT1 project, we were wondering what patients' wants and needs were, and were guided, for instance, by this work of Hopper and colleagues, who actually found that patients are really ready to use these wearable devices. And importantly, they thought that the neurologist should help them in device control. Also, they did not want anything, a hat or something, a cap. They did not want anything, a patch on the face. They didn't want a brain implant. And actually, quite a few thought that seizure prediction would be very interesting, besides generating emergency calls and documenting their seizures. Julie already showed the classification of epileptic seizures, and the epileptologists will know that there are so many seizure types that it is fair to say that one digital biomarker will not fit all. So if we look at the different seizures, focal and generalized, there are some seizures with motor phenomena which can be picked up by movement sensors and EMG, such as the tonic-clonic seizures. We have seizures characterized by autonomic auras, such as ictal tachycardia, hyperventilation, and the sensor dot will provide these biosignals to detect this type of seizures. And importantly, it, in my view, will be one of the first to have the hallmark biosignal of epilepsy being the EEG. But you should know that, for instance, in focal impaired awareness seizures, ictal EEG will detect the seizure in only 40 to 60%, while in absences it will be 100%, and tonic-clonic seizures also 100%. I see this as the main problem, and we have to tackle the three big problems. First of all, the wearable should be comfortable, easy to wear, and give good biosignals. Second problem is it will generate a tremendous amount of digital data, which we have to analyze, and we have to find a solution to do that in an easy way. And finally, the neurologist should be able to use the data in daily clinical practice and use it in the management of the patient. So hopefully we'll get there where the patient has a comfortable and discreet wearable that he or she will use. Our engineers are working on machine learning techniques, artificial intelligence, to detect these seizures in an automated way. And finally, we are looking in ways to implement this in our clinical workstation and daily life. So to be fair, it's a medical device. The neurologist is the person who knows the different epilepsy syndromes, knows which seizure types the patient has, and can select the biosignals and modalities of recording the seizures in a personalized manner. For now, we are reading the data offline. And the idea is that we have very good algorithms which can pick up the seizures, so the vast amount of data will be cropped to a manageable portion. And these should have a very high sensitivity. And the task of the neurologist is then to discard the false positives. And I will show how we do this, for instance, with the atypical absences where we are furthest advanced. The CSIT study, the TWO study, is actually a multi-center study to examine clinical scenarios for long-term monitoring of epileptic seizures with the wearable biopotential technology, the sensor dot. And the plan was to start with our full team in different countries March this year. Obviously, that's when the problem started with the pandemic, and the study has been delayed actually severely. And we hope that 4 of the 7 centers will be up and running by the end of the year. Target is to recruit 500 patients. And our main interest is, actually, I will show you the protocol straight away. So we have an inpatient study and a home-based study. And we start with the inpatient study, and we look at typical absences, focal impaired awareness seizures, and tonic-clonic seizures. In this inpatient study, we actually measure with 3 methods. First of all, the standard video EEG equipment of the hospital. Secondly, in addition, the sensor dots. And then thirdly, the seizure diary of the patient. And for this, we use the Epilepsy app, which in my view is very useful. Then engineers are looking at all these data and have come up already with some very nice algorithms to detect these seizures. I will show you one of them in a moment. And we can then apply this in the home-based study. The primary outcome is the F1 score. What is this F1 score? The F1 score combines sensitivity with the positive predictive value. So if these are the relevant elements, in our case, epileptic seizures, we are interested to pick them up all. So have a very sensitive method. We don't want any false negatives. It means that the device has missed it. So we are aiming for a very high sensitivity. In addition, we are interested in the positive predictive value. This means how many of the detections were actually true positive, how many were false positives. Ideally, we should detect only true positives, no false positives. And so this F1 score combines the two. It's twice the sensitivity times positive predictive value divided by sensitivity plus positive predictive value. And the values vary between 0 and 1. 1 meaning sensitivity of 100% and a positive predictive value of 100%. 0 means it's not sensitive and the positive predictive value is very bad. This measure is actually very interesting to compare between devices, and in my view also to compare between the different seizure types, which I will try to do. These are our first results, the in-hospital typical absence study. We have now looked at 12 patients with a median age of 20 years, 7 were women. Median age at epilepsy onset was 9 years. 8 had juvenile absence epilepsy, 2 childhood absence epilepsy, and 2 juvenile myoclonic epilepsy with then typical absences. And to be very clear, for this study, we defined absences in terms of EEG. So a 3 Hz spike and wave discharge lasting 3 seconds or longer. And with this definition, we had 283 absences. So this number is large enough to do already a formal study. And that's a problem with the focal seizures and the tonic-clonic seizures. We will really need recording with all the centers for at least a year, year and a half to get this type of numbers to do the further studies. So methodology, we first in the hospital looked at the standard EEG and marked the beginning and end of these discharges which lasted more than 3 seconds. Secondly, we looked at the sensor.eeg, and actually this was done for these set of patients in a blinded way by 5 different neurologists. So again, they marked the sensor dot start and end of the seizure. In the next step, these 2 EEG files were merged. And then you see here, the ictal discharge on the sensor dot was fitted an ictal discharge on the standard EEG. So this was a true positive. So from this type of data, we could find the sensitivity, positive predictive value, and F1 score of the sensor dot as compared to the standard EEG. This is work of Lauer and Swinnen. And for the typical absences, the sensor.EEG had a sensitivity of 77%, a positive predictive value of 94%, and an F1 score of 0.81. The seizure diary, on the other hand, sensitivity of 5%, positive predictive value of 34%, and an F1 score of 0.009, confirming what we knew, that the seizure diary of patients with absence epilepsy is really unreliable. For comparison, I noted that the same metrics for the tonic-clonic seizures with the devices which are on the market and which are based on accelerometry and EMG detection, such as the EpiCare, Nightwatch, EpiLert, and I've actually averaged the sensitivity, positive predictive value, and F1 score from an article written by Julie Vertru on this subject. And these devices are quite sensitive with a sensitivity of around 90%, but the positive predictive value is around 55%. So quite often you have false positive detections. When the patient moves, it's interpreted as a seizure, which is wrong, obviously. And the F1 score is 0.68. So these first results actually, in my view, are quite encouraging. This is certainly not the end. Reading of the 24-hour sensor.EEG takes 1 to 2 hours, which in my view is really long and tedious. So the engineers have now made a patient-specific algorithm to automatically detect absences, and the sensitivity of this algorithm is more than 98%. And so I read the annotated EEGs, which I got from the engineers, and the median time to go through one 24-hour EEG was a median of 6 minutes, so much, much better. And this is an example. So what you see here is the sensor.EEG, and in green are the markings of the algorithm. So you get this EEG set with all the green markings, and the only thing you have to do is jump from marking to marking, and the only thing you have to decide, the algorithm is telling me this is a seizure, is this correct or not correct? And in this case, I marked, I said, this is correct. Here you see the start of a clear-cut 3 Hz spike in wave discharge. This is an example of a typical chewing artifact. So there is also a learning curve in these EEGs. This is how a chewing artifact looks on behind the ear EEG. This typical 2 Hz with muscle artifact on top of it. So it's easy to discard this as a false detection. What can I say about focal to bilateral tonic-clonic seizures? We have recorded a few. I've read this 24-hour EEG blindly, and I was impressed how easy the signals were picked up. And just for illustration of the quality of the signal, I'm showing this, tracing. So there were 2 sensor dots used, one measuring EKG, this is the EKG channel, plus EMG on the deltoid muscle, which you see here, with some EKG artifact in between. Every sensor dot has an accelerometer, and this is one of the chest. And then the one in the neck measures the 2 EEG channels, plus an accelerometry in this sensor dot. And the first thing that is obvious, the heart rate starts increasing. So the heart rate was here 56, time 5:10:39. 20 seconds later, heart rate had gone up had almost doubled. No movement, and in my view, no clear-cut EEG changes. Heart rate goes up to 126, and then you start to see the ictal discharge in the temporal lobe, a recruiting theta rhythm, and the heart rate still is going up. It's evolving, amplitude is increasing, it's slowing down a bit, and then the tonic-clonic phase starts, which is picked up by the EMG signal and the movement sensors, which you see the changes here. Tonic phase, then we come to the clonic phase, and you see the how the muscles stop jerking, and then finally the seizure stops. There is still tachycardia, no movement, and the EEG signal is fairly flat. There are now new patches in development which can also measure respiration and oxygen saturation. Obviously, for this type of seizure, it will be very interesting to study these biosignals with a view to try and prevent and better understand SUDEP. What can I say about focal seizures? Well, we have a few in the SEIZIT-2 study, but as we mentioned, we started with the SEIZIT-1 in 2016. We didn't have the sensor dot at that time, but we had the idea of measuring EEG behind the ear. And Kaat van de Kasteel is one of the engineers. She looked at 54 patients who had a total of 182 seizures, mostly temporal lobe epilepsy. We recorded more than 5,000 hours of EEG, both video EEG and then these extra behind the ear EEG channels. The first question we had was, can we really pick up seizures in a reliable way with just these behind the ear channels? The second question was, can we now develop a data-driven algorithm to pick these seizures up in an automated way? And she developed a patient-independent model and then a patient-specific model. This means you should have EEG data from a seizure of that patient, which you can feed into the algorithm. And I was told by the engineers that this is actually a very straightforward and easy method to do. For the first question, yes, you can see the seizures quite easily. So what we did was, I didn't go through all the files, but I saw all the seizures. So Kaat presented me with 10-minute sections, and I didn't know whether there was a seizure in there or a false positive. So she used the false positives from her automated algorithm. So these were actually fairly tricky EEGs, so not the easy ones. So sensitivity 66%. And I should also mention on the full EEG, these were only the patients where some changes were seen on the full EEG. So sensitivity 66%, specificity 94%. And from these type of studies, it became clear that the cross-channel recordings were actually easiest to pick up these temporal lobe seizures. And you see on the ipsilateral channel also changes of lower amplitude. With the sensor dot, we have just two channels. So in the focal seizures, we use one across the head and one ipsilateral, ideally on the side of seizure onset. Then she looked at the performance of her algorithm. So these data we already discussed. With the patient-independent seizure detection algorithm, she obtained a sensitivity of 64%, positive predictive value of 39%, and an F1 score of 0.38. With the patient-dependent seizure detection algorithm, sensitivity came up to 69%, with a positive predictive value of 65 and an F1 score of 0.62, which is actually fairly good. Now I should mention, and this is important, this algorithm was designed for online detection. And then it's very important to keep your false positive detections as low as possible. If we are now interested to obtain a very sensitive method so that we can reduce the amount of data and then review and discard the false positives, you get to a much higher sensitivity. So with EEG, you go above 80%, but then you have more false alarms per hour. So this is the sensitivity as a function of false alarms per hour. We haven't even mentioned the combination of the different modalities, and she has tried to combine these. So EKG measurements in combination with EEG. And in addition, you get an additional 10% sensitivity, so you get above 90%. So that's future work. And once we have all these data, we'll try and work this out further. So future studies, as I mentioned, new electrode patches are in development. We will look also at tonic and atonic seizures. Once we have good patches, we'll go for very prolonged measurements. And if that is possible, we'll try and study cycles in epilepsy and try to come up with a seizure predictor. We will study tonic-clonic seizures to get a better understanding of and prevention of SUDEP. And if we go for online seizure detection, we probably go first for the tonic-clonic seizures. As we speak, engineers are also looking at automated sleep scoring from the EEG, and every epileptologist knows that sleep and EEG and epilepsy have several interactions, which is really worthwhile studying. So in conclusion, the sensor dot and plug and patch is a multimodal discrete wearable to detect epileptic seizures. It's a medical device. And I believe that for every seizure type, we will need different registration and analysis strategies. So we are working now in the current project to determine the clinical scenarios, how to best use these devices. Wearability and seeing quality will improve as we go along. We will develop new seizure detection algorithms, and it should be integrated in the clinical daily practice and patient management. And finally, we'll do cost-benefit analysis to obtain reimbursement. In the acknowledgement, there are several partners to be acknowledged, and also our blind readers, Chantal de Pont, Laura Senave, Evelien van Kaasre, and Annelies van Dijken. And this is the team, the Byteflies team, which has grown, as I saw on the first slide of Hans. UCB with Gurli Vertesh, engineers of Stadius, and this is our clinical team. Thank you very much.
Thank you very much, Wim, for this very insightful presentation and the deep dive into all the clinical aspects. It was, I think, very interesting for many listeners. I'll just have one brief question for you, Wim, before we go to the break. Some of the people are wondering how well do you foresee the device to detect, for instance, frontal seizures that you normally see in the hospital on frontal channels, for instance?
That's a very good question. Very often frontal seizures are not well detected on EEG, but very often they have motor features, and we are now looking very carefully at the different motor features. And the advantage of the sensor dot is that when you see that, for instance, there is a dystonic posturing of the left arm, you can put the sensor dot on the left arm. If it is the right arm, you can do it. So we are looking now at these clinical scenarios how to best implement this and how to detect this. And then the engineers had to develop algorithms to get these signals out in an automated way. So I'm quite confident that we'll get far by measuring and detecting also the frontal lobe seizures.
Okay, thank you. That was very clear. And I think with that, we closed off a very nice conclusion that we have to go again for personalized profiling of epilepsy patients. So thanks for the full team. And then I think we will take a break, 5-minute break before we go into the interactive panel sessions, starting with the people with epilepsy and their caregivers. So I'll see you back in 5 minutes. Thank you. So welcome back, everyone. Now, actually, the exciting part is going to start, and not me or Hans talking. I would like to, kick off this roundtable with the most important people in the room, which are the people with epilepsy and caregivers or relatives. And this will be hosted or moderated by two very talented people. First, the very passionate TORIE Robinson. She's CEO of Epilepsy Spark, and I can tell you she literally brings sparks in the room when she's present. So we'll feel that soon. And then secondly, we have Simon Privet, who I met actually on a conference, and we talked for hours about living with epilepsy. He's a very strong epilepsy advocate. He also raises awareness for the general public, which is very important steps. And I think he inspires many other people with epilepsy as well. So they will moderate the conversation with the other members here, and we'll introduce them as well. So the floor is all yours.
Wow, this is great. Thank you very much for having me, everybody. I'm delighted to be here. And you have to forgive me looking at the notes, being a bit of a stereotype person with epilepsy. I guess my memory was not the best. So I will be checking these notes. But yes, I do want to encourage any questions that people might have. If you've got any questions, even if it's a bit personal, I don't mind that. I'm sure Simon doesn't mind either. Just go for it. And if you like as well, we can answer any questions afterwards too. So the goal of the roundtable today is to provide people with epilepsy and caregivers a platform, a voice by discussing the hardships, gosh, that's such a strong word, but it's true, that are encountered on a daily basis, and how much they vary indeed, and show people with epilepsy that they are heard, that they are seen, that we acknowledge them, and that Byteflies is actively looking for solutions, which it actually is solutions to better our lives basically, and manage our seizures if possible. That would be great. And I could just say this line, but I know that it's true given my work already with Byteflies, but they actually value the feedback of patients and carers. So a bit like what I said before with the questions, any feedback is positive feedback, constructive feedback. So a bit about my story. I was going to say I'm female, vaguely. It's my 40th birthday the other day, and I was diagnosed with epilepsy when I was 10 years old. Although I recall having seizures years prior to that. My epilepsy got worse and worse the older I got. It progressed from focal and absent seizures through to secondary generalized tonic-clonic seizures, which was fabulous. And I had refractory epilepsy. Nothing worked, none of the treatments that I've been on so many drugs, I can't remember all of them. And it got to the stage where I'd been without controlled seizures for over 20 years. I actually flew back from Australia where I was working at the time just because my seizures were, and actually psychiatric comorbidities had gotten so severe. I was very lucky to be suitable for a temporal lobe resection, which I classify as being very successful. I still sometimes have seizures, but I'm kind of like still alive, which if I had not had this, the operation, I wouldn't be here today. My risk of SUDEP at the time was very high. And I decided after surgery and a lovely stint in a psychiatric hospital that I didn't have anything to lose by speaking out more about epilepsy and by giving other people a voice, because not so many people, not everyone is lucky enough to be able to articulate what they go through with epilepsy. And so I set up a blog, which ended up becoming Epilepsy Sparks. I started doing public speaking regarding epilepsy, both for charities, but for corporate organizations. And now I've done talks in Australia, in India, supposed to have done it in the States, but obviously that's not happening right now. And in Brussels too, lovely to meet Byteflies there. And it's just brilliant today to give other people a voice. So the first person that I'm going to introduce to you is Nico, whose surname I can't really pronounce. Sorry, Nico, but Zabla. Now, Nico is an enthusiastic biomedical engineer at Freiburg University Hospital, Germany. I've already asked him, like, I want to learn more about what you do. And he's been working with Byteflies over the past year as part of the larger SEISE-IT2 multi-center study, and has a personal interest in innovative technology to improve seizure detection, given his own epilepsy diagnosis. So, Nico, welcome to the talk. And well, first question, what aspects of epilepsy, well, tell us just a tiny bit about yourself, but also what aspects of your epilepsy have been particularly difficult for you to live with, go through, etc.
Thank you, TORIE, for the lovely introduction. Let me just answer your question by telling you my own story. When I started to have my first seizures, generalized myoclonic seizures at the age of 17, and for those who don't know, these are small muscle jerks with a short loss of consciousness, and it feels like a short break in which somebody turns you on and off again. And after these seizures, my mom was really worried about me and urged me to go to a neurologist. And then I went to the neurologist, and I got the diagnosis juvenile myoclonic epilepsy at the age of 18. And at that time, I finished school. I wanted to travel around the world. I want to get to know new people. I want to find my limits. And what you don't want to hear from your doctor is then you have to sleep regularly, you have to avoid long parties, you should not do drugs, and you should not do anything which sounds a little bit of fun. And at that time I was really struggling a lot with myself, and I tried to take the medication which my doctor told me to take, but I did not become seizure free, and I also became very sleepy from this medication. And so I decided not to take the medication and just ignore my epilepsy.
Dude, you don't do that. I've never done that before, by the way, just so you know, but yeah, carry on.
It was really not my best decision so far, but I still, then after that, I had my myoclonic seizures, and sometimes once a day, sometimes only once a week, and I was not allowed to drive. I had also problems staying concentrated and focused, especially when you have to write, when you have to pass an exam or something. It's really a big problem. And after some years, I got a generalized tonic-clonic seizure in the age of 22. And luckily, nothing really bad happened here. But maybe to answer the question, I think there are a lot of things that are difficult for people with epilepsy. But I think the most difficult thing for me was just to accept that I have epilepsy. And my mind had changed after this big seizure. And some years later, I can find myself as a data scientist who's trying to work on helpful devices for people with epilepsy, like people from Byteflies. And I'm really thankful.
And I hope you're actually following the rules provided by your neurologist now, right?
Yeah.
Yeah, good. Okay, and I'm sure you can answer this very well. So what technological advancements do you wish there were to help you and help other people affected by epilepsy?
I think I have two things in mind when I think about technical advancements, which I would like to have and which I'm dreaming of since I was diagnosed, I think. The third thing is of all an objective automated digital seizure diary. Like I changed my medication 4 weeks ago from levetiracetam to pirivacetam, but I still don't know if the new medication is really working or not. So objective diary could solve such a problem. And the second big thing is a device which detects generalized tonic-clonic seizures, because these seizures can be very dangerous for people with epilepsy. And when I had my first generalized tonic-clonic seizure, my friends knew how to deal with it, and luckily I was lying in bed. But what happens when there's nobody around me, and what happens when I'm not lying in bed? So it would be very helpful to have something which could alert a caregiver or something.
It's interesting you say that, especially for tonic-clonic seizures. You've actually just given me a flashback. I fell on a railway line when I was having a focal seizure, which did turn in, but during the focal seizure. So it's like these things are beneficial for every person really with epilepsy. It doesn't just have to be these scary seizures, you know.
Like for me, especially, like I have the small seizures. I think the device should not alert a caregiver when I have a small seizure, but when I have the big one, the dangerous one, I would like to have an alert for that.
It's interesting. So it's different for every person, isn't it?
Yeah,
so,
it is.
Yeah.
Every time it's individual.
Sorry?
It's always individual for every person.
Yeah,
every
and
epilepsy.
that's really important to recognize. I think we're all so different, different attitudes towards, you know, our epilepsy, seizures, and other aspects of our lives. So do you feel that there is a need, well, you kind of answered this, but for continuously monitoring your epilepsy in the home environment? So you're not outside, you're not going to fall on a railway line, but why is it important at home?
Of course, it's important at home because, yeah, as Julie already said, when you're in the hospital, you only have 5 days to monitor the seizures, and the most seizures happen at home. So it would be really helpful to have a device at home. Yeah, I think that's it for my side.
Yeah, and I don't know if this has happened to you, but lots of people I know will go in to have video telemetry, have an EEG in the hospital, and they don't have seizures. And as soon as you come home, you have the seizures. So it'd be great to do it at home instead, right?
Yeah, but at the end, the system had to work. Like there are a lot of systems, they just say, yeah, they work sometimes, or the sensitivity of the device is not as good as that. And so I would like to use such a device, but it has to work at the end.
Quality, right?
And I think that kind of covers off exactly where Byteflies are trying to go with this. Nico, thank you so much for sharing your story, and I wish you well with the work that you're doing with Byteflies. I hope it produces some really positive results for you and others with epilepsy. So for those who haven't met me before, good evening. My name's Simon Privet. Thank you for the wonderful introduction, Julie. A little bit about me before we move on to our next panelist. So my epilepsy story started when I was 14 years old. I had a seizure at a family Christmas party. I was very lucky. One of my brothers was a trained lifeguard, recognized the symptoms and took control of the situation. But it was very scary for my family to witness. And being aged only 14, it was pretty scary for me as well. Over the following months, I had more and more seizures, and wasn't really sure what was happening to my body, and it left me feeling a bit different to others. And then a few years later, sadly, unfortunately, I lost a cousin as a direct result of an epileptic seizure, which really threw into kind of stark reality for me how costly epilepsy can be. Once I'd received a formal diagnosis, I was able to start anti-epileptic drugs, and I've tried many over the years. I consider myself very lucky now that I've been seizure-free for coming up for 2 years, but it's taken 20-something years to get to that stage, trying different medications and dealing with different side effects over the years. But at least my seizure type has been narrowed down to impaired awareness focal to secondary generalized tonic-clonic seizures, which doesn't really mean a great deal to me as a non-epilepsy specialist, if I'm honest. But the experiences that I've had over the years drove me to promote awareness for epilepsy and provide support services for people with epilepsy. So I now run 3 support groups in my local area, and I've been doing so for a number of years. But I've also also been interested in technology for my entire life. I like to consider myself an early adopter of modern technology and wearable tech, at least when money allows. So when I met Julie at the International Conference for the Technology and Analysis of Seizures last year, as she mentioned earlier, it was natural for me to be interested in the technology and the potential for that technology that Byteflies had to offer. So I've been following their progress with some interest, and that's why I'm here today. So thank you for the invite, guys. So that's me in a nutshell. So I'd like to introduce our next panelist, which is Jean-Luc. So Jean-Luc's story is a little bit different to mine and TORIE's and Nico's. So Jean-Luc doesn't suffer from epilepsy, but in order to care for his daughter, who's been living with epilepsy for about 15 years, Jean-Luc's been investing a lot of time into supporting sensibility campaigns. With these initiatives, he hopes to inform and educate the general public so that bystanders are better prepared when someone has a seizure. And I think for those of us that have been in situations where we've had seizures in public, we all know that there's absolutely a need for that. So Jean-Luc, good evening. Welcome to the chat.
Thank you, Simon, for the nice introduction.
You're welcome.
You're 100% right. I'm not suffering directly from epilepsy, but I do suffer indirectly, I can assure you. And I'll give you the parent, the dad's view or the caregiver's view. My daughter is now 26. She's been suffering from, she had her first seizure when she was 11. And yeah, it's been a long way since then, 15 years, all type of seizures. So I'll answer your questions anytime you're ready.
Absolutely. Well, I mean, I guess the most obvious place to start is you have a different perspective from those of us that have been before being a caregiver. So what aspect of your daughter's epilepsy has been particularly difficult for you and for your daughter to live with?
Well, it changed over the years for sure, because she started as a teenager. But if I try to summarize everything, one of the biggest difficulty was not to be allowed to live a kind of normal life. Overprotection from the parents, and I'm responsible for that for sure. The fear of injuries. She's falling when she has a seizure most of the time, so there were a lot of injuries through our life course, and that leads to a lack of social life, which is probably what has been the heaviest burden for her up to now. And it goes along with some discrimination, stigmatization. That's why it's so important to inform the population about epilepsy. But the main thing is really the overprotection, which it's hard to accept for the parents to leave her alone, and it's hard to accept for a teenager or for a young adult to be always under kind of monitoring, or at least parents monitoring or anyone else monitoring, with all the psychological problems that can come along with that. So yeah, in a nutshell, that's really I could tell you many different difficulties, and you know that for sure. You've gone through that, but this is really what I would the main one.
I noticed several of the points you made. There were heads nodding kind of around the room. So it's, you know, there are similarities between all the different people with epilepsy, even though some of the things are different. So what technological advancement do you wish would be invented, or be, that would exist, that would help you to kind of relax a little bit more, knowing that your daughter was able to better manage her epilepsy?
It depends how realistic I am. I'm dreaming of something that could heal her forever, definitively, for sure. A tough expectation would be something that would predict the seizures. And Professor Wim explained us about the research in that field. That would completely change the life, for sure. More reasonable is seizure detection and alarms connected to the detection, because the alarms would allow us to leave our daughter to have a normal life, and most of the patients would have a normal life, knowing that they can alert others in case of a seizure. We've kind of gone around that problem with, we've been very lucky. My daughter has a seizure alert dog. So that fantastic dog sometimes predicts the seizures, always detects and informs around him. So it really changed our lives. But, you know, growing up a seizure dog is a very tough process. It takes time. It does not always work. So if we could have a kind of device that can replace that, that would be fantastic. And it all goes, more independence gives more confidence. And you know how important is confidence in epilepsy, stress and everything. So it allows you to enter a virtuous circle. And so coming out of a vicious or negative circle and entering into something much more positive. And that's what we are currently going through. So I'm very optimistic with that and very positive with that.
Excellent. Thank you for your answer, Jean-Luc. Do you, just off the back of that, do you feel that there's a need for continuous monitoring at home? I mean, would that allow you to feel more comfortable leaving your daughter to have more of a life to herself?
Very close to the second question. To detect and to alarm, you need to have some kind of monitoring. So yes, it's very important for that. And another positive point of monitoring is that it's, well, we discussed that earlier in this webinar. The accuracy of the diary is key to the neurologist. And if the neurologist has better information, he can give better medicine to the patient, and he can limit the secondary effects and improve the efficiency of the treatment. So yes, I think it's something very useful. And it could be also not only at home, it depends how wearable it is. So in the first stage, yes, it would be at home, but hopefully it can be something that nobody can see and you can have it anywhere.
Absolutely. Thank you for your honesty, Jean-Luc. Thank you for sharing your experiences.
Thank you very much to Jean-Luc for what you've been telling us, how open you are. And I think it's really important to hear from the perspective of family members and carers, which brings me on to Stephanie, whose name I'm sure I'm almost pronounced again. I apologize, Stephanie, but Stephanie de Jonga, who is the mum of a 14-year-old daughter who also has refractory epilepsy. 2 years ago, Stephanie founded an organization called Stimmung Kinder Epilepsy, a patient organization regrouping families confronted, and I think that's a good word for it, with refractory pediatric epilepsy. So the organization focuses mainly on peer support, so family members who really get it, what it's like to be the family member, and they provide both emotional and practical support to create awareness and understanding between different members, but also sometimes to have someone just to speak to. And the word catastrophe has been used, and I think that's very fair as well. Well, however you classify the word, the epilepsy being severe or not, it impacts your life considerably. So, Stephanie, please tell us about yourself and exactly how you got to where you are today. And the official question is, what aspects of epilepsy have been particularly difficult for you to live with, cope with, and that of your daughter? So please tell us more.
Thank you very much, TORIE, for your nice introduction. Well, our story begins 8 years ago when epilepsy came on our path in a very brutal way. There is no other word to say it. With no history of epilepsy, my daughter had a refractory status epilepticus of 3 hours and a half after 1 week of undefined fever. Happily, she survived. We've learned afterwards that mortality rates linked to refractory status epilepticus is quite high. So I'm pleased that I didn't know that at that time. Since then, my daughter suffers from refractory epilepsy. In her 8 years journey, she's never been seizure-free for a steady, long period. We've tried numerous therapies, including all possible anti-epileptic drugs, study medicines, immune therapies, plasmapheresis included, ketogenic diet, and neurostimulation. She's currently on 4 AEDs and has a VNS implanted. Although our sense of urgency never disappeared or has never lessened, we learned to somehow accept the fact that actually she will probably never be fully seizure-free in her life, even though that is very difficult to accept as a person, as a parent, especially for me as a mother. My daughter's epilepsy has an impact on every aspect of her life, and also on our lives and on the lives of her brother, smaller brother she has. There are several difficulties for us as a caregiver, as a mom or a dad of a child with refractory epilepsy. The most important ones for us are, first of all, the chronic stress that comes along with it. Chronic stress has really, and I'm an example of that, has really a negative impact on both your mental and physical state. And I can say that at a moment in time, I really needed help. So, secondly, there is the fact that for us specifically, the mental development of our daughter doesn't follow her physical development. So you see a girl who is growing up physically very well, but her mental state doesn't correspond to her physical development. And it takes a lot of energy every day to adapt to this mismatch.
By mental, do you mean intellectual? Just to clarify, do you mean intellectually?
Yeah, indeed. She has, for example, mental flexibility is very, very difficult for her. Indeed, her brother, who is 11, he knows much more than my daughter. My daughter is, for example, has difficulties with calculating simple things, with everything. Actually, she has a severe intellectual impairment. So she's in special school, and indeed, the fact to see that happening, but in the meanwhile see her growing up physically like any other child, and this mismatch is really, really difficult for us as a parent on a daily basis to live with, to accept every day, and to be aware of every day. Oh yeah, it's true. She has a problem with that, or she has a problem with that. So yeah, it's quite challenging. And I just wanted to say also one thing concerning the difficulty that my daughter is confronted with, because I asked her, and she says that it's the lost time she's confronted with because of her seizures or the consequences of her seizures. She can't spend as much time as anybody else at school. She can't be with her friends. She can't spend time at social activities. So it's like a big part of her life that on an intermittent basis is erased each time. And it's very difficult for her to live with.
You can tell that actually I really understand where she's coming from. I really do. I had to cope with the same thing growing up. Well, still today, you just have to say no. It's like, am I going to have a seizure, or am I going to have some sleep, or whatever. So going on from that then, I mean, have I missed one of our questions? Yes. What technological advancement do you wish, could be presented to you that would help your daughter and you? Like, what would help you relax and chill out a bit more?
Mm-hmm. If we could dream, then actually our daughter has several kind of seizures. She has both focal and generalized ones. Mm-hmm. And she also has a very specific one that she calls the physis, and she says to Mom, Dad, there are the physis again. And usually those physis happen just before a bigger seizure. And with physis, she means like tingling in her cheek or in her hand or in her arm. And unfortunately, those physis aren't always measurable with the current technologies. Which is for us as a parent frustrating, because we see the physis happening and then afterwards the big seizure. And when it can't be measured, it seems to not exist. And that's quite frustrating, and because it's unexplained, it's like a mystery. So we would like a tool to be developed that can inform us of even the smallest epileptic activity, like her kind of physis. Yeah. Because it could learn us if yes or no there is a link between the epileptic activity going on in her little head and the reactions she has or the behavioral issues. Yeah. It would be a tool that can in a way objectify what we feel as a parent is going on in her little head, and that could bring for us some peace of mind, or also make us able to react more accordingly or appropriately, to the situation. Because there are days when she says the physics are there again, and I think, oh, what are you saying? And if a tool could just objectify that there is nothing going on, then my reaction is perhaps okay. But if a tool says at that moment, there is epileptic activity, then I would probably be able to react more appropriately to that situation.
Yeah, I guess you never know if you're doing the right thing or not at the moment, do you? Because you don't really know what she's experiencing.
No,
that's anticipated.
That's really, really frustrating. Yeah.
Yeah. So I guess that leads us on really to the third question, which was going to be, do you feel there's a need for continuous monitoring? And it sounds like you kind of answered that. Like, what do you think about continuous monitoring in the home for your daughter? Would that be a benefit?
I do think there is a need for home monitoring on a continuous basis, but also on an intermittent basis. We would use it. We would use it in those situations where we think that something is going on, or, for example, as that changes a lot, when her medical scheme, when her medicines are adapted. In that situations, we would use it, but not all the time, I think, because making her wear that all the time at her age is probably not so easy to do.
Not necessarily seen as a cool trend yet. Perhaps we can change that. But okay, and it was lovely to hear from the perspective of you as a mum, and I think that rarely gets heard. It's lovely to know as a former child who had epilepsy, that there are mums and dads out there who really care. That means so much, because not all children have that. So thank you very, very much, Stephanie. So I'd like to reintroduce you to Simon, who is going to officially introduce Kent now.
Thanks, TORIE. Thank you for your words this evening, Stephanie, as well. It's really lovely to hear from you. So I'd like to introduce our final participants this evening. So we have Kent Watson joining us from the United States. Kent's a retired computer analyst who's been committed to raising awareness and reducing the stigma around epilepsy. And we're also lucky to be joined by his wife, Beverly, who's been his caregiver for many, many years. So Kent, Beverly, good evening, or I suppose, is it good afternoon for you?
Yes, yeah.
Yes.
Thanks.
Yep.
I guess kind of quickly summarize my my case. I guess it's kind of different from the others because I started having seizures back when I was in my 30s. I had what they call nocturnal seizures. I would have them while I was asleep. My wife would say, "You had a seizure," and I would say, "Well, I would take pills each day and just kind of be tired or whatever and go ahead do about my business." I had to go ahead and start working with computers, and back in my day, that was before internet, before having computers and the cloud and all of that sort of thing. This is kind of surprising to have this sort of thing. Was not even thought of to have people across the world talking together. That's all amazing to actually even think about this sort of thing. But over the last 6-7 years, I started having day seizures, and that's completely changed my life, because with that sort of thing, I had to give up driving. I had to give up my work completely. I did work in computers. Most of it was doing database type of work, but anyway, that's completely changed things, because I had to retire early in my life. But I went through a video EEG, and the doctor said we can't do any kind of a brain surgery because my seizures were coming from both sides of my brain. So they said we maybe should have a VNS installed. The VNS plan promised to maybe reduce my seizures. It really didn't. It maybe reduced it a little bit, but the promise of reducing my taking pills or whatever might help, but it really didn't. The VNS hasn't really reduced it that much, and looked at it, and I have about 4 or 5 seizures a month. And so, my doctor, then we had moved to Colorado where I live now, and the doctor said, well, maybe you should have an RNS implanted, and that meant having going to the hospital. What would they do? They would drill these little holes in my head and look at me, and I might stay in the hospital for maybe 3 weeks and wait for a seizure to happen. That was not really what I wanted to do, to stay in the hospital for 3 weeks and wait for a seizure to happen. That's both expensive and not, sitting in the hospital for 3 weeks waiting for a seizure to happen. So I said, no, I don't think I want to do that. Since then, I have learned that both the VNS and the RNS are not that successful. RNS may take 4 or 5 years for it to become that successful. So I'm kind of start looking at maybe other means of finding out about how seizures might happen. At this point, when I have a seizure, I don't have any kind of warning. When I'll be working away and doing something, and the next thing I know, I've passed out. I fall a lot of times. I'll bruise my sides. One time I fell and I broke my glasses. My wife is pretty much with me most of the time, which is good. But she'll help me out. Help me back to the bed, and I'll sleep for an hour or two, and then wake up. She says, "You had a seizure," and I'll go ahead and maybe sleep the rest of the day. But one time I was walking into the garage, and I cut my head and I was bleeding. We had to go to the ER room and have it patched up. Another time I fell in the grocery store. People had to come around me and help me out. Those sort of things happen, and it's difficult for those sort of things to happen. But that's the way it's been for me. So one thing that's happened here, I've helped people with similar kinds of seizures, and we have a support group here that's we've tried to help other people that have seizures. But that's the way things have been. One thing in my lifetime, I've seen a lot of different technologies that have come about. That's the way we came in across Byteflies. We had one of your representatives, Ben. I can't pronounce the last name, but he came in and came in one of these Zoom meetings and explained how Byteflies, as the sensor dot, has helped people, and we're just kind of anxious to see how this technology is going to come about.
Lovely. It's really good to hear your story, Ken, and it's quite clear that it's had a huge impact on your life these last few years when it's changed from the nocturnal seizures to the daytime seizures. And I'm kind of conscious that we're a little bit pressed for time, but I'd just like to ask Beverly, what technological advancement do you think would help you and Kent manage Kent's epilepsy better?
Just to have it so that we would know when they would happen.
Yeah, so you're kind of looking for something a little bit more predictive, do you mean, or do you just so that you know when Kent's having a seizure?
When he's having a seizure, it would be helpful because he just immediately drops. I hear crashes around the house or things being bumped into, and I know it's him, and I rush to him with the magnet, but he seems to come out all right. He kind of turns purple, but his breathing then returns to normal.
Okay.
I just, yeah.
And just to for kind of round up there, Kent, do you feel like there is a need to have a device that continuously monitors your epilepsy, in home when you're out and about? Do you feel that's something that would be of value for you?
Yeah, definitely. Just some way of knowing when a seizure's happening or about to happen. I've worked with a group actually in Australia that has tells me that there's there's a way to find out when maybe a seizure is about to happen, and I know that there's some work done here in the U.S. that in trying to find out when a seizure is about to happen. That's kind of strange that there's wearable devices, but I think that usually it's something around the arm or the wrist or whatever. But I think something that actually is measuring the EEGs or whatever on your head, I think would be a lot better technology than something that's measuring things on your arm. I think would be a much better way to approach this type of technology.
Okay, lovely. Thanks for your answers, Kent. It's lovely to hear from you both. We've kind of got a chance to answer some questions, but I see we haven't got any come in at this point. If anybody's got any questions for the panel, do feel free to ask. Including Julie, have you got any questions for the panel?
No, go ahead.
Panel, can I ask somebody a question, please?
Yes.
Yes, go on.
Well, I wanted to, I was having a conversation with somebody else today and recognizing that sometimes I think having somebody that you love affected by epilepsy can be more traumatic at times than for the person that's actually having the seizure. At least I say if I'm having a tonic-clonic, I'm not conscious, so it's awful afterwards and it's awful beforehand, and it's awful as a other thing in general, but I'm not worrying really about myself, like me personally, but I think for parents, it's a different story, and I think that needs a bit more attention. What would you say?
I agree. I totally agree. Me, for myself, my husband, even the little brother of my daughter found it very traumatic to see the seizures of our daughter, but I don't think that my daughter herself finds it so traumatic. She found her own way to live with it, but on being a parent, being a brother who sees it all the time, it's a whole different situation, and it causes, in our case, and I know I'm not the only one, it even caused a post-traumatic stress syndrome. even, and gladly there are very good therapists, psychologists here in Belgium who can help, but even her smaller brother had a post-traumatic stress disorder, can you imagine? And my daughter, she hasn't. She is scared when she has her physis because she feels coming a bigger seizure, but she isn't scared in the same way as we are. She hasn't that traumatic feeling as we have it.
Yeah.
I kind of disagree, if you allow me, TORIE, and I'm a little bit embarrassed with your question, because I don't think there's a need to make a kind of scaling of the difficulties or the pain. It's art for everyone, for sure. But if I want to be completely honest, I prefer to be on my seat than on my daughter's seat. It's really tough for the patients, it's tough for the parents, for the caregivers, for everyone. And anything we can do to improve their lives or our lives will be welcome, for sure. That's why we're here.
Thank you for your comments, everyone. I think it's fairly easy in terms of summarizing, what we've discussed this evening, that epilepsy is it's a catch-all term for a whole group of seizure disorders, and a lot of people have very different seizures, different experiences, but there are certainly some themes of commonality, and actually it's fairly self-evident that the information available through a Byteflies sensor dot allows us to take that data back to a clinician and avoid some of the confusion of seizure diaries, etc., and makes that really objective data really useful, and brings a whole new tool to the arsenal of things that we can use to try and help improve the lives of people with epilepsy. So thank you very much, everyone, for their opinions. Have we just had a question come in?
It's a comment more than anything from I think sometimes it just really helps parents and loved ones to know that you're not alone feeling the way that you do. Just knowing that can help a great deal, I think. Yeah.
I'm glad you've been able to read that one, Tori, because that crept up on me. Thank you very much, everyone, for your involvement. And I think we'll hand back to the Byteflies Lounge now, guys.
Thank you, everybody. I do want to say thank you for the heartbreaking stories. I think that really motivates us even more to work hard and make sure that a solution will be available between you and your neurologist. At least for me personally, that's gives me an enormous drive. So thank you for your openness, and I would say stay healthy, please. And now we'll take another 5-minute break. Let everything consolidate, and we'll then continue with the second roundtable, which will be 4 international neurologists that will also give their take on what is needed and what are the challenges from their point of view. So thanks again, everybody, and please stay in touch. Have a lovely evening or afternoon. Welcome back, everybody. Thank you, all the neurologists from joining all over the globe. For some, it's good afternoon, I see. So I want to kick off the last interactive session, which will be guided by our Chief Medical Officer, Ben van den Driesche. It's a mouthful name, but he has been, in the epilepsy work, he has been there from the start. He has he's very medically trained, has a lot of knowledge, and actually a lot of Bytefliers learned from him. And he's going to take over the moderation for this session. And we are very much looking forward to the perspective of the clinicians. So Ben, the floor is yours.
Thank you, Julie. And good afternoon or good evening, everyone, depending on where you are in the world right now. So we already heard what Byteflies and our partners have been working on. As well as there were some very interesting discussions to be had, especially with the epilepsy advocate panel, where we heard some very personal stories. So next we'll continue with you as the panel, and you all have, to some degree, some of you a lot, have firsthand experience using various devices and novel technologies to help your patients. So to start off with a brief introduction for everyone. So we have Professors Lieven Laga from the University Hospital in Leuven, Belgium. We have Arjun Sen from Oxford University Hospital in the UK, Yvonne Weber from Aachen University, Germany, and Dan Friedman from New York University in the US. So thank you so much for joining us and for taking the time to be here. It is very much appreciated. And so before we kick things off, a couple of housekeeping notes very briefly. So I think Julie already mentioned it earlier, but for the people in the audience, please don't hesitate to use the Q&A function in Zoom to ask any questions you may have. I can't promise we'll have time to get to them during the live discussion, but the team will definitely try to answer all of them as they come in. So without further ado, let's dive right in. And we'd like everyone on the panel to spend 5 minutes or less to tell the audience what they think is an important challenge that you've personally experienced when treating people with epilepsy that could be solved or at the very least improved by home seizure monitoring. And if possible, if you have a particular example from your practice that you could give, that would be very much appreciated. And Professor Sen, if you don't mind, we could start with you.
Okay, thanks very much, Ben, and good evening, everyone from Oxford. It's great to be with you all this evening, and it's been a fascinating introduction. I particularly enjoyed hearing from the patient advocates and parent or perspectives, as well as perspectives of people who have epilepsy. I'm an adult neurologist and head of the epilepsy research group here, and I wanted to pick up on a couple of things. So I think that one of the things that and I hope I'm not stealing anyone else's thunder in saying this, one of the things that technology can really do is try and move a condition that is unpredictable to hopefully being more predictable. And we're not necessarily talking about seizure prediction just yet, but seizure detection is critical to that. And technology is going to be, I think, the way that we really try and solve that conundrum. As I've mentioned, I was struck by lots of things that were said in the people with epilepsy session. But what I wrote down, one of the things I wrote down was what Nico said very early on, which is that he felt that epilepsy had taken away the fun and he wanted a return of fun. And I thought that was actually a very good way to put it, because what the condition can do is it can disempower you. And what I hope, and I think all of us are trying to do together as a community, is re-empower. I'm not sure if that's a word, but let's say it anyway. Re-empower people to have better control of their the situation. So in terms of a specific example, so as an adult neurologist, I thought I'd think about something that people from the pediatric sphere might find interesting. And so we do a lot of work on the intersection between epilepsy and dementia, and in particular, the intersection between epilepsy and Alzheimer's disease. And in people with Alzheimer's disease, it's now increasingly recognized that they are more prone to having seizures, and that seizures may actually contribute to the condition, so contribute to the cognitive difficulties that people with Alzheimer's disease experience. So for example, in Alzheimer's disease, there's a condition called amnestic wandering, when people can seem somewhat distracted and may move around the care home for a period of time. And that's generally been thought to be part of the condition, but that actually may have an underlying ictal basis. And it's very hard to pick up that kind of data, because the person with Alzheimer's disease may well not recognize it, and even the carers may not recognize that that might be something that is of clinical relevance. So one way that I thought that Byteflies and SensorDot could really help is by trying to detect subclinical seizure activity, which may then in due course lead to modulations in therapy and so on and so forth. And again, we heard in the panel discussion just before that it may not be possible for people to wear the SensorDot for prolonged periods if there's cognitive impairment. But I think it will be more possible than wearing ambulatory EEG, which is what we do at the moment. So, which is the full headset of electrodes. And partly because we have this special interest, we have great technical support from our neurophysiologists and neurophysiology technicians. We do that in people with dementia to try and see if we can detect subclinical seizure activity, which again then we could look to modulate. But I do think that the SensorDot device may offer us a new avenue to try and detect that, and it has a clear therapeutic goal as well. So those are my initial thoughts, I guess.
All right, thank you very much. Just to follow up on that, maybe very briefly before moving on to the next person. So you have a particular focus on people with Alzheimer's and the detection of subclinical seizures is a very specific application for you. Is that for your practice the #1 application that you can think of? Or do you say that is where I currently see the biggest need? Or do you feel like it is, because it's your research, that's what you're focusing on? Of course, it's an important aspect to continue focusing on, versus the clinical practice of getting people to monitor their seizures more frequently.
Yeah, great question. Well, actually, though, what I was trying to do was pick something that other people wouldn't say, because I worried that you would come to me first. So if you'd come to me last, I might have said something completely different. But it's slightly harsh to now turn the tables on me all of a sudden. But so that's
sorry about that.
Why I said that. No, I think it has application much more broadly. Dementia, though, epilepsy in older people, and you heard Kent and Beverly talking very eloquently just before the break about the impact that seizures can have in older people. The world demographics are changing. The older populations, both here and in resource poor settings, are increasing very quickly, and epilepsy is more common in older people. So I think that what I was really highlighting by the answer is that age shouldn't be a preclusion to using novel technologies and having access to novel technologies. It's then very much your choice as to whether you wish to explore it, but that option should be available across the age spectrum. In terms of where you can see it more applicably in, well, I maybe won't say it because I don't know what everyone else is going to say, but I can give you a more, if you like, a more immediate example once everyone else has had a go, I think.
Thank you so much for that. So with that, we can move on to Professor Lara.
Hello, good afternoon and good evening to everybody. I'm very happy to be here. I'm a pediatric epileptologist working in Leuven here in Belgium. So I mainly see children with difficult to treat epilepsy. And you might know that this is a completely different world from adult epilepsy, I would say. So I'm very happy with the progress that actually is made by Byteflies. It's amazing what they did in a couple of years. And now I consider this as a starting point because now we have this platform. And actually, this is a new world for us, for epileptologists and especially pediatric epileptologists. So we have to learn to do the right interpretation of these signals. And I think the combination of the signals, of the biosignals, will give us many more answers. So I'm very much looking forward to this new research tools, and it will be applicable in clinical practice. So from my point of view, I think we have to shift from the very obvious generalized tonic-clonic seizures. I don't think we need a device to detect daily or tonic-clonic seizures. I'm not talking about nocturnal seizures right now. Also for absence seizures, I think we still have to discuss what is the real value. But there is a value, of course. So I think we have to move to detecting more subtle seizures in pediatric epilepsies. And also subclinical seizures. I agree with the first speaker. I didn't prepare this, but subclinical seizures is really important to pick up in pediatric patients. Now, to illustrate what could be possible, I have two cases, actually, two real cases in my practice, quite astonishing cases. The first one is a lovely girl of 14 years old. And she's known with ring chromosome 20, so difficult to treat epilepsy, intellectual disability, lots of seizures, and she was always tired, and she had actually refractory epilepsy already for years. So we put her in a study with a new promising anti-epileptic drug, and to our surprise, she did the best in the study. She became really seizure-free. So everybody was happy, but the parents were not happy at all. I mean, they were a little bit happy, of course, but the child continued to be very drowsy and tired during the whole day. She could not perform. I mean, she's in special school as well, but even there, she could not perform at all. So we did a 24-hour video EEG, diagnostic video EEG. And then we found out that she actually was not seizure-free. She had like 24, or I mean, I'm saying something out loud now, but more than 20 short-lasting tonic seizures during the night, nothing during the day, disrupting the full sleep architecture, and probably that was the reason for the sleepiness during the day. So in a way, for the study, for the company doing the study, this was a great case. She became seizure-free. And actually looking at the EEG data, she still had a lot of seizures during the night that we didn't recognize before. So if you would have a system like what Byteflies is now using, I mean, a home monitoring, this would have given the answer. I mean, we could have known before that this child was not seizure-free and that we still had to do some work for the nocturnal seizures. So that's one particular case where I think this device might really be helpful. The other case is even more difficult. This is also a girl of 8 years old, SCN2A epilepsy. So again, very refractory epilepsy. And she was quite well controlled in the sense that we didn't see any convulsive seizures anymore. So we were happy, no dangerous seizures, but here the parents were complaining about fluctuations during the day. I mean, sometimes this child would do okay, other times she would be quite quiet and do nothing. I mean, she is again very intellectually disabled, but even then the parents could make differences between active periods and inactive periods. And then it's very easy to say, okay, this is part of the syndrome, don't worry. But again, we did a video EEG, and we could find out that these inactive periods, that actually these were subclinical, or not subclinical, but seizures, but not hallmarked with convulsion or motor activity. So this was like hypomotor seizure or a dialectic seizure, as we used to call it, not absence seizures, actually temporal lobe seizures. So again, if this would be measured at home, we could have learned a lot from that case and not think that she's really seizure-free. So these are just two cases to illustrate that we really need such a device. But on the other hand, to finish, I think we have to warn also our colleagues that do not overinterpret the EEG. So we don't need a device to only look at EEG changes. We need to look at seizure types and seizures. So we have to find the right combinations between EEG signals, biosignals, and the behavioral changes as seizures. So that's what I had prepared.
Thank you so much. That was a very, very clear answer, and thank you for throwing in the cases. That always helps to understand how, you know, a device like this might have an impact on people's lives directly or indirectly. Moving on, Professor Weber, would you mind going next, please?
Thank you very much to have me here and to discuss this very interesting and very important subject in epileptology and with patients and colleagues. That's great, thanks. And I'm working with seizure detection systems right many years before also I got in contact with Byteflies, because I saw that we had this big need in therapy of patients. Because as Professor Lagarde said, it's always a negative surprise when you ask the question, how many seizures do you have? Because the answer is in most times wrong. Because patients don't know, nobody knows really how many they are, and they are changing over time. Even if you don't change any medication, all we know that seizure activity in refractive patients, they change dramatically, and nobody really knows why, but it's a changing system. And it's not only that we have many patients having seizures they don't see, or relatives, we have the other way around as well. So we have many patients carrying 5, 6 tablets in combination with many side effects, but don't have seizures anymore because the behavioral changes or any other things are overinterpreted, because of course caregivers and patients look to those patients since many years, and it's an overinterpretation of behavioral changes. So what I wish from a seizure detection system, what would be optimal in the future, is the possibility to get also fine-tuning for medications. It's not only to know if the seizures are gone, but just before, if the seizure types are changing, and if I really need that high dosage or not. And in the end, when you know exactly how the seizures in a special type of patients are running, that you really know early, now they are stopping, and that you don't need the high dosage, for example. So this is only to give another idea where a seizure detection system may help. The other thing is, as June said, patients with Alzheimer's disease, for example, or patients with mental retardation, as we have here as well. So we have also pediatric patients, adult patients, and also adult patients with severe mental retardation. There you never know if this is a seizure in the night or if there's only a behavioral change, and would be very helpful to have a detection system. So we ask many patients to come back to the monitoring unit, not only for pre-surgical evaluation, but also to check if they have seizures or not. And this is only available, of course, for patients having many seizures per day or per week, but also patients with 3 to 4 seizures per month, which are not to be treated, then it's negative for them in the long-term run for memory development and side effects of medication. So this is what I would like to say.
All right, thank you very much for another very clear description of how this type of technology could end up in the hands of not only patients, but of course you as neurologists too, and how you would apply it or could apply it in your daily practice. And then last but not least, Professor Friedman.
I think, I'd like to echo what the previous panelists said. I think they're all very important reasons why we should continue to support, as neurologists, continue to support and validate these tools. I think that we are at a disadvantage compared to our diabetology colleagues. They have a very easy, simple blood test, glycosylated hemoglobin, that they can order and understand the burden of the disease they're treating, whether the patient needs more or less medication, escalation of therapy, and things like that. We have imperfect tools. We have patient or caregiver report, which we know is inaccurate, and I think that a simple blood test is probably unlikely, or probably a long way off for a complex disorder such as epilepsy, but devices that can help us assess seizure burden will fill that gap. The other thing that these devices will help is actually, I'm an adult epileptologist, it will help our patients with independence. I think that many, especially younger patients, are maybe overly supervised by their family, who is concerned that they're going to have seizures that are unnoticed or unrecognized, and may feel restricted in terms of going out and living on their own, going away to college or university, moving to another city because of their epilepsy. But I think also having tools to monitor patients will be helpful for the many patients who currently live alone and have unrecognized seizures. So I'll give you an example of a patient I saw last Thursday. It's a woman who's in her late 40s, intractable epilepsy. She failed a left temporal lobectomy many years ago, continues to have seizures, lives alone. And I see her and I ask, well, how have your seizures been? And she said, well, they were pretty bad in the summer, where I was having about one seizure a week. And then starting in September, I haven't had any until this morning, when I had a seizure while waiting for the bus to come to this appointment. And I said, well, what happened between the summer and the fall? And she said, well, I stopped going to the pool. What do you mean? And she said, well, during the summer, I spend most of my days at the pool in my apartment building. And there are usually other people around. And they tell me when I have seizures. And the pool closes in September. And, mostly I spend time in my apartment, maybe talk on the phone or watch television. So, and the story is the most likely situation. She's still having seizures. There's just nobody around to tell her that she's having seizures. And indeed, when we brought her in for diagnostic prolonged video EEG monitoring, she was having a seizure, a focal unaware seizure, about once every other day.
All right, thank you so much for your take on this pretty high level question, and I apologize for that, especially to Professor Sen, to figure out where this technology could be useful. And I think the takeaway here is also something that we've heard from talks before, and especially the patient panel as well, that there is no one size fits all, right? There are so many different circumstances to take into account, that there is no single wearable device that is magically going to be a robust solution for a very broad group of patients and people with epilepsy. So on that note, before, I don't think we have any pertinent questions from the audience right now. So moving on, I took a couple of notes on what you were all saying. And in addition to that no one size fits all theme that I hear coming back, I also hear not only, or actually less focus on, there is a focus on seizure counting. That's of course very important. We're all aware of that. But there was also, I think by almost everyone, at least an indirect point about, let's call it quality of life, or the ability to have your independence, the ability to make seizures more predictable, and so forth. And I think that's kind of exactly also for us at Byteflies an incredibly important thing to figure out, and not an easy thing to figure out. Like, what is that balance between something that is providing clinically accurate information that can be used by all of you to help your patients better, but also directly or indirectly improved quality of life of that person and give them more independence. So the to move on, unless there were people in the panel that wanted to comment on what somebody else said, please speak up or interrupt me at any time if there's something that you would like to add to what was said. If not, to move on on a similar line of thinking. So we've talked about this device that potentially can be used for a few weeks at a time. We're now talking currently about something that somebody could wear for a year or even longer than that. We're talking about a few weeks here, a few weeks there. And then when thinking about a device like that, of course, the types of signals that that device can measure is critically important. We already heard about, there's EEG, ECG, EMG, and other biopotentials, and certain measures of motion and activity and other types of behavioral signals that can be recorded. So knowing for you that you would move to a situation where you would start sending some people home with a device where you have no video and no audio feed, and that you have a limited number of EEG channels that can be captured in addition to these other channels. Like, from your experience, like, what is the single most important other signal that you think a wearable device needs to be able to record for you to kind of compensate for the lack of video or audio feed that you would typically get in the EMU?
Perhaps I can start by, the answer is exactly what you said. No one thing will fit everything. I think we have to move into personalized diagnosis, not personalized treatment yet, but personalized diagnosis. So I still believe that for many patients, there is one type of seizures that really is a combination of ECG changes, movement changes, motion changes, saturation, EEG. So I think we should put some effort in trying to identify the typical seizure for one particular patient, and from there on, probably you have the start of predicting a seizure in that particular patient. So I would say that we are now starting to understand this combination of signals. Out loud, ECG is really important, but I think if you talk about SUDEP, saturation might be more important. So it really depends on what you want to study. But I would go for personalized diagnosis in every individual with epilepsy with your device.
Thanks. Yeah, I just echo that completely. And it also ties in quite well with what Dan was saying about that there isn't an HbA1c for epilepsy, and there isn't a peak flow that you can measure. But you could conceptualize how, if you use the Byteflies device for a patient while they were in the epilepsy monitoring unit, so you're capturing simultaneous the full EEG plus using the Byteflies data, you then know what the signal is on the sensor dot for a given person's seizure. So you know what their personal signal is in terms of the more limited channels and ECG changes and so on and so forth. So you could then anticipate that sort of, let's say 6 months, 12 months down the track, you want to monitor again and see how things are, rather than coming back into the EMU, which is incredibly expensive as a test, and also very disruptive to people with epilepsy, having to take a week or longer out of out of everyday life, you then say, okay, well, now we use the Byteflies device because we know the signatures that we're looking for that correlate with your seizures. And we can then better adjust treatment. And we sort of effectively create an HbA1c for that specific person's epilepsy. So I think that that would offer great potential going forwards, and having something non-invasive and discreet would be particularly helpful in that setting.
So in your use case, you are talking about somebody, like having somebody come into the EMU first, based on what you learned there for their seizure signature, use that information to, despite the fact that the wearable device will have less information, there won't be 20 channels of EEG to go from, there won't be a video feed, but that will help in identifying that signature and pick it back up when it happens.
I think that's right. I think that potential is certainly there.
You know, I also want to highlight the potential use of this type of device for differential diagnosis. So sometimes we're not sure if events are seizures or other types of spells, whether they're arrhythmias or faints, or they're perhaps functional seizures, dissociative seizures, or psychogenic seizures. But yet they occur infrequently to be captured under standard inpatient video EEG monitoring or ambulatory EEGs. And a longer term device may be helpful for diagnosis. So if you're while the a limited montage EEG, such as the Byteflies systems, may not capture all seizure types, it certainly would be expected to capture seizure types where there is loss of consciousness or convulsive activity. But if you couple that with, that limited EEG with a simultaneous ECG and EMG, you may be able to arrive at a diagnosis for these infrequent events. There's now a lot of there's emerging literature, for instance, about the patterns of myogenic activity, of muscle contractions on surface EMG, and its utility in distinguishing epileptic from non-epileptic seizures.
Yeah, I think when I would like to add only two small points. One point is that we have to be creative concerning the biomarkers we are measuring. So for example, this can be not only EEG or ECG, can be also special muscle artifacts. So for example, or eye artifacts. So it's rare, but you have sometimes patients where the seizures are starting with eye blinking, and you won't see any EEG activity at that stage because you have an external EEG. And what you use also when you scan the EEGs in the night and you have many pages to see and look very fast, then sometimes you can watch for the special muscle artifacts in this patient, and you see the artifacts before you can see the EEG activity. And I think the second point I would like to add is that we will learn more what we call subclinical seizures. Because we saw in our on the other project, we saw that what we call subclinical seizures in the night are not really subclinical. So we had several patients stopping breathing in that time, and we didn't look before for that. So that means there's something happening clinically. It's not much, but it's not subclinical. So I think we will change our view on what is clinical or not clinical seizures. It will be important as well.
Thank you for that. And I especially liked your comment about that we need to be creative with the data that we can collect, especially with the multimodal data. There's a lot of underused potential in the fact that these different physiologic signals, they influence each other, right? And to give one very simple example, but still a very underutilized one, just the fact of the matter that with a wearable device like this, you have the combination of activity monitoring together with heart rate increases, which you would also get on a fitness tracker. But here we get all that raw sample level data. So you can actually start looking for very specific prototypical patterns in the accelerometer signal while there is a heart rate increase, which may tell us a lot of things that we're simply not aware of yet. And especially since you're all involved in one capacity or another in the CZ2 trial, the fact that we are reporting the full video EEG data, and we have that to compare to the data we get from the wearable devices, that data set should really help us uncover some of these patterns that we're simply not even looking for yet. At least that is my hope personally, and I think that is kind of the point that you were getting at. So thank you for that. We are getting some questions from the audience. So before going into that, there was actually one more thing that I would really love to hear your opinion about. That is kind of an extension of what we discussed just now. And that is the fact that, and Professor Van Pasen in his talk highlighted that as well, with the amount of data that a device like this will collect, you need some form of algorithm to be able to handle it, because there's just too much of it to go through manually. And so if you assume for a second, for the sake of the argument, that we would have a very highly performant algorithm, and it's known, it's been proven, it's been validated that it produces very few false positives. In that scenario, do you see any reason why you, as a neurologist using a device like this to send a person home and look at their data, do you still see a reason to be able to pull up the raw underlying data, the raw EEG, the raw ECG, or do you say, there is a specific set of conditions where we would be okay with just getting the events reported, but we don't need to, or we don't have the time anymore to look at the raw data?
Yeah, that's killing our profession. I think we still want to see the raw EEG, for instance, to validate the patterns that we would see with the Byteflies. But once that we are confident that this is really telling the real story, so that's a one-to-one match, then I would trust it and do it automatically. But I personally would like to be able at any point to look at the raw data for any type of seizure, not only for localization, because that will be not important here, but also for the morphology. But we still have to learn all these things with the new device. We don't know how the morphology will look like. If you say polyspikes on a classical EEG, how does it look like on a Bytefly sensor.EEG? It's not completely the same. So again, we have to learn this, and in the beginning, I think we will have to validate it and control it a little bit with the raw data that we used to use. So don't kill our profession.
But I will say that at the same time, the majority of people with epilepsy are not cared for by epilepsy specialists. They're cared by general neurologists who don't read EEGs. And I think having something simple for them, once if such algorithms are validated, where they can be presented with just a simple histogram. This is when and how many seizures occurred since your last visit, would really spark adoption. And use for many patients out in the community. But that said, I agree. I think the ability to look under the hood of those detections, and I think in addition to morphology, I think duration, and what happens after the seizure terminates are also important pieces of data that we look at when we're talking about the burden of the seizures, and I think the most likely scenario, given the diversity of seizure patterns in our patients, is that detectors will be maybe sensitive but not very specific, and I think that what will the likely scenario will be a situation where we'll have a lot of detectors that will reduce the review burden for epileptologists, but we'll still need to quickly see and get rid of the false positive detections.
That makes a lot of sense. Thank you.
I'll be quick. Yeah, so I very much agree. You can, I mean, the analogy, for example, is if you do prolonged cardiac monitoring. So you could do prolonged cardiac monitoring, and you could have something that detected when people went into a supraventricular tachycardia, for example, and it would just say that there was a tachycardia at this point, but the cardiologist would still want to see the morphology of that tachycardia, what exactly was happening, not just what the rate was, but what was the lead into it, what was the morphology of the ECG at the time of the tachycardia, how did things settle down afterwards. So while I think that SensorDot offers great potential, there will, I hope, still be a need for neurologists and neurophysiologists going forward.
Yes, okay, the optimal scenario would be we don't have any false positive, but I think, yeah, we will ever have false positive, and it's a question of how many false positive you would accept, and I think this is depending on the seizure activity the patients have and compared to the false positive. So it's a question of rate to rate. How is the rate of false positive that really disturbing? This is one point, and I think the other point is that I definitely would control everything in the beginning and would like to see all raw data, especially to look at the marks, where's possibly the seizure. And what's correct, what Professor Laguerre said, that we would have to learn how a seizure look like on the 2 electrodes or 4 electrodes we have, because this would look different compared to what we know to look like. And also to recheck if the marks are correct is, in my view, very important. And what Dan said is that the very negative side of epilepsy patients that's in real time, they're really not treated by trained neurologists in epileptology, what would be the perfect thing for people who are therapy resistant. So I think, in my view, it's fine. Epilepsy patients who don't have side effects on medication and are seizure free, that they are treated by neurologists. But when we have the 20 to 30% of refractory patients, they should, in my view, definitely go to an epileptologist. It's not the real world, I know, but I think we have all to work on this. That in my view, a refractory patient means 2 medications and after, and all epilepsy patients having their first seizure should see an epileptologist and having the possibility to learn about expert knowledge. But of course, that's my dream for the future.
All right, thank you so much. So we have a few minutes left, and I'd like to grab a couple of questions that came in from the audience. So one question that came in is it an interesting point of view to go to a personalized diagnosis from patient to patient. Will this also need a change in policy and or payment, depending from country to country? Payment reimbursement is based on standardized practices, for instance, one-time video EEG per year, whereas having flexibility on this from patient to patient could help as well. Agree or disagree? I think it would be good to manage time if one or two of you who feel particularly inclined to answer this try to tackle it. I'm not sure if there's any volunteer.
I'll do it then, because in the NHS it's different, because obviously we did that payment question. Fortunately, we're very lucky that doesn't really come up. And certainly healthcare professionals are not thinking about that when they're guiding patient care. So the NHS does still have to be utilitarian, but the idea that we were talking about before, being able to use the sensor dot technologies, having personalized it beforehand, actually would be dramatically cost saving. So I can't see how that would be necessarily a disadvantage. But in terms of that payment concept in healthcare is quite alien to us, I guess.
I can speak from the perspective of a different healthcare system. But I think it is increasingly recognized across medicine in the United States that remote monitoring for chronic diseases is cost effective, and there are now reimbursement codes for physicians to perform remote monitoring, whether that's results of glucometers, weights, sleep apnea machines. So I think it's becoming an accepted part of medicine, that type of personalized monitoring.
Dan, can I actually ask you a follow-up question on that? Because just at, sorry, Ben, but at AES, what was being discussed is, in the session Epilepsy in the Time of COVID, is how a lot of previously healthcare had to be face-to-face in order to be reimbursed. But COVID has obviously transformed that, and a lot of healthcare is now delivered remotely. And so now the reimbursement is for remote access. So I guess that perhaps offers a template as well, speaking to what you just said, that actually you can be reimbursed for remote data capture and doing things from a technological perspective rather than everything having to be face-to-face in a hospital.
Correct, and as many things in neurology, the cardiologists have been there before us. So the utilization of implantable cardiac monitors took off significantly once there were reimbursement models for reviewing those data outside of face-to-face clinical encounters. So now cardiologists actually get reimbursed for reviewing the results of these implantable loop monitors every month and providing reports based on those review to the referring physician. Thank you.
There's a couple more questions. It would be great if we can keep this format going. I think it works really well if everybody, if people who feel particularly inclined to answer it speak up. The question is, how do we translate the personalized diagnosis using sensor dot into clinical drug study design, where regulators like FDA want to see clinical seizure counting in a homogeneous population? That is not an easy question.
Well, I guess we have to change the FDA. I mean, we cannot stick to their historical designs of drug trials. I mean, as has been said, we have to be creative. We can do much better than diaries and sterile descriptions of seizure types like drop attacks or whatever they always said to use. I mean, we have to come up with better descriptions of seizures and then look at the effect of the medication on that particular type of seizure. And I would also, I mean, that they really have to make a move in that. If you look at the drug trials, it cannot continue like it is right now. So we have to be at the forefront and try to change the policies, I think.
It's a very clear statement. Thank you.
I think there's an opportunity to do this now for earlier proof of concept studies, where it's actually studies that the companies are doing to understand whether or not to pursue commercial development of their drug, where they're not, they don't need to report seizure frequency, so it's an opportunity to help companies de-risk early proof of concept studies by providing them with a less noisy measure than patient-reported seizure counts.
Maybe one last question that we had come in. So based on what you know from your participation in season 2 and what you've heard today and our other interactions, what is, if you need to name a single thing, could be more than one thing, but let's try to stick with a single thing that would make you confident that you can start integrating a device like SensorDot into your clinical practice, what would it be?
Evidence comes from that I would see that the detection is correct. So that, as I said before, so yeah, we have the patients in the video monitoring unit. We see the special biomarkers defining this patient's seizures. And these biomarkers are given to specialized detection system. And when the patient comes back, then I can really see in the EEG or wherever in which biomarkers, okay, this is what we saw also in the video EEG monitoring, what was detected there. And I think when I can re-see that it's a correct detection by myself, then I would say, yes, it's working. But I think we will maybe have also a proportion of patients where it is working really good, and the other way, a proportion of patients where it's more difficult. So this is what we will learn also in the future.
Well, related to this, I was a bit surprised actually listening to patients. They don't care too much about false positives, especially if you look at nocturnal devices. I'm talking now about online alarming devices. So of course we would like to have high reliability, sensitivity, specificity, but patients don't mind getting up 3 times at night and 2 times for a false positive and 1 for a real one. They want to not to miss the worst one. So I was really surprised that they didn't bother about the high number of false positives with other devices. So, as an epileptologist, I really would like to have reliability. And for the future, I think nocturnal and online and alarming would also help for a lot of pediatric patients, but I don't think that's your primary goal right now with the device, but that would also be very important for a lot of patients, I think.
Thank you. And with that, we are out of time. There's a couple of questions from the audience that we didn't get to. If anybody had a specific question, we will try to follow up in the Q&A directly. So thank you again, all of you, for joining us and the very, very insightful discussion. As mentioned before, it is very much appreciated, not just by myself. I know for a fact it's appreciated by the entire Byteflies team, and I hope the wider community as well. So with that, we can wrap it up here, and back to you, Julie.
Thank you, everybody, for your very insightful comments and this very interactive discussion. A lot of things to think about. And actually, with that, I want to transition towards the last talk or closing words from Hans De Clercq, who will try to consolidate the key feedback that we heard from both people with epilepsy as well as just now from the neurologist. And actually, yeah, Hans, we look forward to hear how can we live up to all these requirements that are out there? Where are we in the near future? And what is our long-term future plan to be helpful towards both neurologists and people with epilepsy?
Thanks, Julie, for the introduction. I get the honor here to close this event. First of all, I want to thank all the speakers, all the participants. I learned a lot. Not only the speeches, but mostly actually the sessions of the people living with epilepsy and the neurologists were for me very, very insightful. So thank you very much. Epilepsy for us as at Byteflies always has a very important role. It was the first disease we jumped on. You heard from Hans in the first presentation that we are focusing on all patients with chronic diseases. So we are not focusing only on epilepsy, but epilepsy was the first one we focused on. And like Hans also explained, our mission is to bring impact to all these chronically ill patients. And the Byteflies factor, the number of patients we reach times the value we reach, the clinical value that we can aim for, that we can have for these patients, is super important for us. That's our company-wide KPI, and that also shows us that epilepsy for us is very important. You hear it in the speeches of Julie talking about 30% of patients with people with epilepsy being refractory, needing to cope with very difficult situations in their lives. You hear Wim van Basten talking about all these digital endpoints that we can create. Also, that is for us very important, to build our technology and to build something that can measure a lot of the different vital signals and then connect that with the applications. I still know about the moment that this all started 5 years ago. Choosing epilepsy was also a little bit coincidental at that moment. I just finished my PhD. I started Byteflies together with Hans De Clercq, and we just before I finished my PhD, we did a very small project. It was a project, a student project. We won a contest with it. It was a smart glasses with heart rate sensing, motion sensing, eye motion sensing in it. And we just finished that, and together with Bori Hunyadi, one of the students of Wim, who was doing a postdoc and starting a postdoc at that moment in Leuven, we started discussing somewhere at a restaurant, what can we do more with that? And her PhD was about epilepsy, and she told me, like, yeah, actually we're measuring already eye motion. Can we not measure brain waves, and can we not do something with that? And it started like that, very, very small. We tried to collaborate, university, with a very, very small company, 2 people. Today we have a very big team. I'm super, super glad with all the work that we already did. We have 500 seizures measured. We have 250 people with epilepsy measured. We are collaborating with a lot of different neurologists, super, super strong. And I just want to use this presentation to take a leap in the future, to show you where we want to go towards now, because this is not the end goal. We still have a lot of work to go. So a first glimpse in the future is we need to have better patches. I call it a do-it-yourself electrode. Today, if you want to measure EEG signals, we still need to go to the hospital. Cup electrodes is still the way to go, and that needs to change. We need to have electrodes, patches that patients can use themselves, that have the same quality, and that we could use for a week instead of for a day. We don't need this dry out of electrodes. So that's the first improvement that we want to do. And for that, we started Plug and Patch together with Nito, Quad, and Henkel, very strong partners in that field, to build better patches. So that's the first thing that you can expect as an improvement on our devices next year. A second part is data science. Data science is also very important. I think one of the most important things, and I hear that a couple of times coming back, especially by the neurologists, is a very strong feature in our system is we have the raw data. So we provide raw data. You get the same data captured that you normally capture in a hospital, you can capture at home. We have the same quality, we have the same data rates. So EEG, it's lesser signal, lesser channels, but the quality of the data is the same. We can measure heart rate, we can measure ECG, EMG, motion, and so on. But if we go to more data and if we go to more personalized data, it becomes more and more difficult and more time consuming to go through all this data, especially for the neurologist, who now is not only looking at the data from the patient in the hospital, but in the future also looking at all the data from the patient they sent home. And that is way too much. And like you already heard, we're working on algorithms already for some time together with the group of KU Leuven and UZ Leuven. Next slide. I don't think this is working, is it? Yeah. Previous slide. We are building now these same technologies, these algorithms that the engineers of Leuven together with us are developing. We're embedding these things on top of our data. So we are augmenting our data with views. So imagine as a neurologist that you don't have to spend 2 hours to look at your 24 hours of data of the patient, but just 10 minutes, like Wim already explained in his presentation. And then the next slide, I show the last glimpse in the future is we want to build dashboards. And now today, our devices are just passive loggers. We need to build dashboards around them so that we can give more, so that our users, the patient and a neurologist can track themselves or their patients much better. So that's what we were building. So these are things that we were building in 2021, next year. Moving back to 2020, for us, 2020 started as a wonderful year. It was the fifth year of Byteflies. We started a super big, nice team. And as a present to the team, we went in February, end of February, beginning of March. We did a trip to Switzerland to go skiing. So for us, the year started very, very great. And then that Corona hit. And I just want to talk about what that did with our company this year. So Corona hit, and actually for us, it hit it very hard because, as you can see, we went skiing beginning of March. We didn't know yet about what this Corona wave would do in crisis would do in Europe, but then we figured it out ourselves because 90% of us came back from Switzerland with Corona. And by having that, and at that moment, we were actually also doing field tests in the field. We were looking at COPD, we were looking at heart failure, and we were building heart rate patches, respiration patches. And we figured out that actually the same vital signals that we were using, heart rate, respiration rate, SpO2, and temperature, also had a very big value for Corona patients, for ourselves. We were then the Corona patients. And that's why we started an initiative called COVID Care at Home. So with COVID Care at Home, we reached the hand to all the hospitals that we saw in Belgium. Actually, the biggest goal of COVID Care at Home was to help hospitals bring patients home. Bringing patients with COVID home makes it possible that patients get better treatment, better quality of life, because they can be treated at home, a better situation, they are with family, but also for the hospitals in that moment, in a time of crisis, that have a lot of patients to deal with, we can help them with bringing patients faster outside of the hospital. We built this dashboard to follow up their COVID patients, and we asked these patients to measure 4 parameters: breathing, respiration, so respiration rate, SpO2, heart rate, and temperature 3 times a day. And based on that, we collected all that data, and we could calculate the early warning score and give more information to the hospitals. With that technology, we also are extending our own technology on top of that in the next slide, which shows you that with a patch, we try to automatically measure these signals. So the same 4 signals, so that this happens automatically for the patient, but also continuously, which gives even more insight for the doctors. And with that, we reached in Belgium in 2 months' time a very big group of hospitals. 25 hospitals are today using this technology to send COVID patients home. Today we already reached, so this is 25% of the hospitals. And with that system, on the next slide, you can see that in 2 months' time, we also increasingly are helping more and more patients. Today, we are helping 200 patients to recover at home instead of in a hospital. And this shows us actually that today, something that we believe in is that telemonitoring is born. The crisis that happened this year, and that we felt in the beginning very much ourselves, but also now everybody is feeling this crisis. But for us, this also shows that healthcare should fundamentally change, and 2020 will be the year that this is changing. So reaching 25 hospitals in 2 months' time, going for 200 patients, is for us the first time that we really go to that outer circle, the circles that Hans explained in the first presentation, really going to clinical care, really going to the clinical practice, and really going directly to the patients. This is the first time, and it made us realize that we should pivot. And that's actually the last thing I want to introduce here before I close the session, is next year, we want to bring the same context also to epilepsy. And in the 2 slides, and then you can see that EpiCare at Home will be launched. EpiCare at Home is actually the same thing as COVID Care at Home, but for epilepsy. We want to bring this technology to the next level. So from now on, and this is the official launch of this, from now on, we will start reaching out to hospitals, we will start reaching out to patients, and we will bring this technology as close to you as possible. So that is what I had to say in this closing session of, for the rest, a very wonderful Byteflies Epilepsy Day. Thanks for listening.
Thank you, Hans. I won't add too many words to that. I think you closed off very well. I just want to point out to everybody listening and neurologists there, if you have any questions, feedback, positive, negative, please reach out. We're always available. We always want to hear how we can improve and get closer to these solutions. So with that, I want to thank everybody also behind the scene, because we're sitting here in the spotlight, but there's a lot of people helping outside as well in our team of 25 people. Thank you all. I would say stay healthy, keep in touch, and also thanks to all our partners for the great collaboration.